Hello, I'm Steve D'Antonio, Executive Vice President of Shatterproof, a national nonprofit dedicated to reversing the addiction epidemic in this country. My role at Shatterproof is a 180-degree career pivot, as I previously spent 30 years working for a major Wall Street bank running global trading businesses. Today is one of those amazing new moments for me, as I have the distinct honor and privilege of interviewing Dr. John Kelly, a world-renowned doctor of psychiatry in the field of addiction medicine. Dr. Kelly is the first endowed professor of addiction medicine at Harvard Medical School. He is the founder and director of the Recovery Research Institute at Mass General Hospital. He is the program director of the Addiction Recovery Services and the associate director of the Center for Addiction Medicine at Mass General. He has served as a consultant for the US federal government, the National Institute of Health, the United Nations, and several top addiction treatment centers in the United States. Dr. Kelly has published more than 140 peer-reviewed articles, reviews, and chapters in the field of addiction science, and was an author of the US Surgeon General's report on alcohol, drugs, and health. As a licensed clinical psychologist, he is actively working with individuals and families fighting substance use disorders. In short, Dr. Kelly is a treasure in the field of addiction medicine. Dr. Kelly, it is great to see you again.
Steve, it's great to be here. Thank you so much for the very kind introduction. Great to be here with you. Thanks for having me.
I must ask, how are you doing in this very difficult COVID-19 world?
Well, yeah, I'm adapting. Have adapted, I think, reasonably well. Trying to, like all of us, trying to get through it, and as best we can. So I've been trying to get out for a walk every day and trying to get some sun, some fresh air, some exercise, and stay connected. So I'm plenty busy work-wise, and so I'm able to do quite a lot of work, which is keeping me occupied. So yeah. So I mean, I'm one of the lucky ones for sure.
Well, there's no doubt about the fact that you're busy, and adaptation and connection. Those are two great words. What were the headline conclusions? What were the main things that came out of this study?
Well, the first thing to recognize in this review is that it was a comprehensive review in that it included the possibility of any study, except that the studies had to be very rigorous and they had to be comparative studies. So they had to compare AA or 12-step oriented clinical treatment that was designed to get patients with alcohol use disorder involved in AA. And they had to compare it to some kind of comparison treatment. So it could be cognitive behavioral therapy, motivational, some other kind of active treatment, or it could be a waitlist control or non-treatment. We didn't find any of those studies. It was always compared to an active treatment. And then they had to be prospective. So it had to be longitudinal designs where they compared groups of patients who were either randomly assigned to receive a 12-step treatment versus something else, and then followed up over time. So we included studies that had that high degree of scientific rigor only in this particular review. There are lots of other reviews which include less rigorous studies, but given the nature of the Cochrane system that we used to conduct the review, we only included these very rigorous studies. So there were 27 trials in the review, 27 studies in the review. 21 of them were randomized controlled trials. That's considered to be the kind of the highest degree of scientific rigor because patients are randomized to different conditions. We also included economic studies. So there were 5 economic studies in the review, which looked at the healthcare cost benefit, or the cost benefit, if you will, of recommending patients attend AA versus a treatment that doesn't do that. And we looked at the savings from doing that because, of course, AA is free at the point of service. So that's one of the advantages of AA. You don't have to pay anything for it. So people with different levels of socioeconomic status can access it for free. So we included those very rigorous studies. And what we found was this. essentially on most outcomes. This would include intensity of drinking, consequences from drinking, longest periods of abstinence, addiction severity. 12-step treatments in AA performed about as well or a little bit better than other treatments like cognitive behavioral therapy. But where we saw a bigger advantage in favor of 12-step in AA was its ability to produce higher rates of continuous abstinence and remission. And this is where AA really seems to come into its own, is that it helps facilitate these higher rates of remission in long-term remission and abstinence. Here's the other thing, the other major finding, in addition, as productivity savings, which is the major contributor to economic burden, which is people not going to work because they're sick from their substance use disorder. So there undoubtedly are going to be savings there also, but this was just purely on healthcare costs. That's right.
So, and was that equal across people who just went to AA and people who had treatment that linked into AA, or was there a difference between the two on the cost side?
So these were, studies that linked patients to AA principally.
Okay. Got it.
There was one study, one economic study, which just looked at patients who went to AA without a clinical linkage, and they compared those patients who just went to AA after they developed an alcohol use disorder, compared those to patients who selected into outpatient treatment, and those patients who were just in AA actually had better outcomes over time at a much cheaper cost because they didn't use treatment at all.
It's free. Yeah. You can't get cheaper than that, right?
Right. Yes, exactly. Yeah. Yeah.
So,
yeah. So, yeah.
So when I read your study, the thing that jumped right off the page was what you just highlighted. And that is improved rates of abstinence at 12, 24, and 36 months. And we all know that, relapse is a really big part of it. Was that the thing that jumped off the page for you, or jumped out of the study for you? Is that, are those markers at, 1 year, 2 years, and 3 years? And yes. I believe it was high confidence in looking at your studies.
Yes, because, it's actually very hard. If you know the treatment literature, it's very hard to show a difference between active treatments. So when you compare a treatment, any active treatment to another active treatment, it's very hard to find a difference between those active treatments. They normally produce similar levels of benefit right across the literature. No matter where you look, you'll almost invariably find that when you administer and implement some kind of behavioral psychosocial treatment, you're going to produce the same outcome, not a differential outcome. Here was something different. And I think the reason why a 12-step treatment produces these higher rates of remission over time is because we know that alcohol use disorder and substance use disorders more broadly are susceptible to relapse over time. We call them chronically relapsing disorders. And so people often make a good start, but then encounter problems and have difficulty maintaining it. So this is where, when you think about it, when you're treating a chronic illness, you want to be able to engage people, not just for 3 months or 12 weeks or a shorter period, but for the first 3 to 5 years of you want to engage them in something that can help them maintain remission over that first initial 5-year period, because that is the most risky period for instability and recurrence of an alcohol or drug use disorder. So the added advantage here is that you're getting people involved in a free, ubiquitous, indigenous recovery support resource, which is local. It's around the corner from where they live, and it's free. So it's accessible, it's available, it's free of charge. And this is a good example, to me, it's a good example of the kinds of things that we could develop more formally to assist people with chronic illnesses, like substance use disorders, that we can use this as an exemplar of the kind of things that we might do to support long-term remission for people with substance use disorder. And I think this is why there has been now a move and a movement to implementing a broader array of these kind of community-based recovery support resources, like recovery community centers, for example. One of the things I can tell you that empirically, from a scientific standpoint, what we know is that the reason why, because, you could look at these studies that we looked at in this review and say, well, those are clinical treatments. Those are 12-step facilitation clinical treatments. It's not AA. But when you look at the studies that did this next step, which is why is it, to answer the question, why is it the 12-step facilitation treatments do better over the long term and produce higher rates of remission than other treatments? It's because, as you might predict and hypothesize, is because they more successfully link patients to AA. That is the mediator as to why 12-step facilitation treatments do better. And that's why they did better in this review. Now, here's the next question. Well, as you pointed out, Steve, why is it that AA does better? What are the mechanisms through which AA confers that benefit over time? And this is something that has been very curious to researchers, as well as many others, to find out, well, what is it that is it really what some people might think about as spirituality or quasi-religiosity, or is it something more terrestrial and less mystical? What we have found is that one of the major reasons the AA confers benefit is by helping people to shift their social network. So it helps people drop heavy drinkers out of their drug users out of their network and adopt abstainers and recovering persons into their network. And it boosts cognitive and behavioral coping skills, recovery motivation, self-efficacy, which is confidence in one's ability to stay sober, reduces craving, and reduces impulsivity. And those are the empirically supported mechanisms that we have found through which AA confers benefit. Some of the constituent parts of the program itself has been looked at as well. We didn't look at that in this review because they weren't included in most of these studies. But in the vast array of other studies that are included, less rigorous trials than were included in here, where they've looked at, well, what are the actual active ingredients in groups like AA? There's been several studies that have looked at the incremental benefits of involvement, not just attendance, but active involvement. And one of those things, as you alluded to, is what's called a sponsor, having a sponsor. And then you can think of that as like a coach or a mentor, recovery coach or a recovery mentor, somebody who's got more sobriety time than you, who serves, provides that accountability, the check-in, the encouragement, the cheerleading, the support, and the lived experience that people need to build that rapport and trust. Another incremental benefit, in addition to having a sponsor, is actually verbally participating in meetings. So if you actually speak up, say something in meetings, that seems to confer an additional added benefit over and above just attending and over and above having a sponsor. These are additive components to the benefit. So talking of meetings, speaking, having a sponsor, and then there's a linear effect of attendance. So the more meetings you go to, the more likely you are to stay in remission and achieve that over time, with a threshold around 3 meetings or more a week.
Yeah, so there's an element of maybe of structure there as well.
Mm-hmm. Yeah.
So, one of the things that's really interesting, and this is not your research, but one of the things that I've seen is that, people really, they kind of lay their lives out on the line for all to see. And in some ways they're making themselves unbelievably vulnerable. And there's definitely research out there that says that creates incredible connection. This woman, Brene Brown, who's a researcher, has talked about this. And I've seen it in other groups, that when people really talk about how unmanageable their lives are and they share with each other, it does create a connectivity that is that's quite powerful. But the things that you're showing in the science, the shift of the social network, the benefits of being involved, I think they have, they have activities that they need to be responsible for, the accountability, all of that is, it seems like it's common sense, but you've actually done the work to figure out it's real science.
Yeah.
the other thing that is interesting to me, you talked about 12-step facilitated treatment. And I know that you work with a number of large treatment providers like Hazelden Betty Ford, the Caron Treatment Center, that use, they use 12-step facilitation. But one of the things you have in your research is that good treatment centers really focus on aftercare. And one of the nice handoffs would be, once they finish their 28 days, let's say, then what do people do? How do they re-enter the world? Is that part of why they're more successful? You talked about the linkage, but is it about the aftercare?
Yeah. I mean, I think anything you can do to link people who have an alcohol or other drug use disorder to some kind of continuing care. And again, not for everybody, but the people who we see in treatment tend to have the highest severity of alcohol and drug use disorders. Those individuals tend to need ongoing support. And so any treatment that's worth its weight is going to spend a lot of time on that next phase. Probably the most important thing you can do after you stabilize someone, you detoxify and stabilize someone, is to ensure or maximize the chances that the person is going to get engaged in the next level of care. Just because we know, people can start well, but they can fall through the cracks and they can slip through those linkages down the road. So anything that you can do to robustly connect people with ongoing continuing support, the better off you are. I think one of the reasons why these groups like AA work so well is because is the cohesion you mentioned, Steve, that cohesion and social bonding that occurs in those groups. People make these social connections which become valued friendships. And that valued shared experience, as you said, the common suffering, when people are very open and honest, builds, the catharsis and this cohesion and identification and installation of hope that people can recover and that they can do it together.
Yeah, my experience is hope it's really lacking, with families and people who are, just at the very beginning. And I can imagine that a sponsor that has a long period of continuous sobriety is not only providing coaching, but also an example that really creates a significant amount of hope for people.
Yeah, exactly. Yeah.
So yeah. You talk about TSF, 12-step facilitated treatment. Do you think that your research has created is going to push organizations that don't use 12-step at all in their process? It could potentially, because this, as you say, you were really answering the clinical public health utility question of AA, and you came out with a resounding yes. Is this going to change the treatment terrain as to what treatment providers should be looking at in terms of maximizing the effectiveness of their treatment?
I would hope so. Look at this review and look at how they can utilize the science to help patients who suffer from these disorders. I think there's some very good news here, is that we've got a freebie. We've got this freebie out there called AA, which helps support people's, it increases the chances of remission and for more people and over a longer period of time at a reduced cost. So I often talk about this as kind of being the closest thing in public health that we have to a free lunch. So AA and groups like it are the closest thing in public health we have to a free lunch. Think about how many meetings here in Massachusetts. There are about 2,500 meetings a week, just AA. So there's another 600 AA meetings. There are Marijuana Anonymous, Cocaine Anonymous, as well as other mutual health groups. Yep. We shouldn't forget, like Smart Recovery, Life, all these other mutual health groups different flavors. But again, all the power of people, of lived experience and groups to help people sustain these changes over time. So we've got good evidence now that implementing one of the proven strategies, which many of which are documented in the review, that if you use one of those clinical strategies, you're going to increase the chances of remission for more patients and over a longer period of time and reduce healthcare costs.
Right.
I mean, that's a pretty compelling set of features right there. If we improve outcomes and reduce healthcare costs.
But as we all know, people are, they have their opinions. Have you experienced any blowback? I think one of your co-authors alluded to the fact that, that kind of, negativity might be, on the horizon. Have you experienced any of that? Has that been part of what you've had to deal with, or just it hasn't been the case?
Well, I think I haven't personally had to deal with it. I understand there's opposition to various things. I think one of the things that people are opposed to with 12-step is spiritual emphasis, spiritual quasi-religious emphasis. So people are opposed to it on those grounds. But again, what we have found from the mechanisms research is that although it may look like that on paper, in reality, it looks very different in terms of how it confers benefit. So there's some of that, I think, opposition on those grounds, Steve. But again, I think you have to look at the science and say, okay, is the science valid, and can we then utilize these findings to help more people? That's what I would say.
That's a good answer, and I'm in complete agreement with you on that. Let's change a little bit. Your study focused on alcohol addiction. It's huge. It's a huge problem around the world. But obviously, there's a lot of people in this country addicted to opioids, cocaine, meth, other illicit drugs. So let's talk a little bit about drug addiction. Narcotics Anonymous, or NA, is also quite big. 70,000 groups in 144 countries. I know that you haven't done the study, but are there inferences that one might draw between your AA study that could have similar implications for Narcotics Anonymous?
Yeah. There's been I think we can make some extrapolations based on the findings here to other groups, and there is other studies that have been done that look at Narcotics Anonymous involvement. In fact, one of my colleagues and friends, Bill White, who some people may know, just did a systematic review himself of the literature. I actually contributed to it. But Bill did most of it, as well as Keith Humphreys and Mark Gallanter from New York University. He just put that out. It's available, looking at a couple of hundred studies on NA. Most of them were descriptive. We don't have the same kind of scientific rigor regarding NA as we do with AA, in part because, AA alcohol is the big drug, the big domesticated drug problem that we have. But as you point out, we've got plenty of problems with other drugs, most notably recently opioids and opioid overdose and opioid addiction. There's been a few studies that have looked at the added benefit, for example, of using NA in addition to medications, and find an additive benefit. So if you take medications and go to NA, you do better than either one alone. So there's an additive benefit from participation in NA for people with opioid use disorder. There have been more studies looking at stimulants, cocaine, methamphetamine, with 12-step facilitation, showing abstinence rates, again, for those with cocaine addiction who are recommended to attend 12-step groups do better than patients, for example, who get cognitive therapy. There was a big, large trial in the 90s that looked at that. And there's been a recent one with methamphetamine, show a benefit for 12-step or intensive 12-step facilitation.
So you're saying that there's been some work done and it's pretty consistent with what you found with Alcoholics Anonymous, although they haven't been done with the same rigor as a Cochrane review that you used for the alcohol study.
Yes. Yes, and certainly with opioid addiction, what we find when we look at the science there is that medications, we have good medications, which are the first line of treatment for opioid use disorder.
Right.
For example, buprenorphine, naloxone, or Suboxone, commonly known as Suboxone, methadone. Those are very effective treatments for opioid use disorder. And when you use those, they should be the first line because they're the most scientific evidence in support of it. When you add participation in NA, people do even better, significantly better. Yeah.
Which is, it's amazing. So, we know Suboxone, methadone saves lives. You add NA and you're probably saving more lives. Are there other things that you might flag for us that could be, so other than medically assisted treatment, that might be a significant difference or concern about this extrapolation?
A concern from extrapolating from the evidence on AA
to NA. You brought up MAT is a difference, right?
Yep.
So is there anything else, or do you feel like it's kind of green fields? It's this is something that should be studied, and you think that they would likely come up with similar answers to the AA study?
Yeah, I mean, in terms of psychosocial treatment, so when we look at psychosocial treatments, for, again, mostly the psychosocial treatments, where they've been studied in a similar way to the trials included in this review, have looked at cocaine and methamphetamine, because we don't have medications for cocaine and methamphetamine. So it's just been the application of, psychosocial comparisons. And what we find is that, again, when you actively prescribe involvement in Cocaine Anonymous or Narcotics Anonymous or AA for patients with cocaine use disorder, many of them have comorbid alcohol use disorder who have a cocaine use disorder, they tend to do better. They have higher rates of abstinence, similar to the findings from alcohol use disorder alone. We don't have studies, randomized studies of just opioid use disorder with psychosocial treatments, in part because since the 1950s, we've had methadone, now we've got Suboxone, and agonist therapies, as well as long-acting antagonist therapy by way of injectable naltrexone, have shown to be the best treatments for opioid use disorder.
Okay, and just for the people listening, agonist means that. Why don't you describe it?
Yeah, so an agonist, it mimics the effect of has a longer term effect of the same effect of the illicit drug. So if you take methadone, it occupies that same receptor that heroin does. So it enables people it mitigates the cravings that people would normally have. A bit like a nicotine patch does for when you're trying to stop smoking. When you take a nicotine gum or nicotine patch, it gives you a steady dose of nicotine while you attend to the behavioral sides of addiction, the psychological aspects of addiction. So it stops those nagging cravings so people can attend to the other aspects of recovery.
Yeah, so what I'm hearing is that you like the extrapolation. As a scientist, you'd say we do need to do the rigorous study, but you're saying that you're not shying away from the extrapolation from AA to NA.
Well, again, I would say it depends on the primary drug. For opioid use disorder, for patients with opioid use disorder, I would looking at the science, the first line of treatment for opioid use disorder, you would say, would be agonist therapy like buprenorphine or methadone. Now, if you add NA to that, NA facilitation to that, you're likely to improve outcomes even more than you would just by giving people the medication alone. So that's where I go in extrapolating to opioid use disorder. I would extrapolate them more readily to other stimulant use disorders like cocaine and methamphetamine.
Yep. So in this COVID-19 world, AA did a really good job putting meetings online. It was the only option in many places. I'm sure you've participated in one too many Zoom meetings like I have. And it's clear online is very different than in person. The vibe is different. In the case of AA, one of the things I'm sure you know about is the after meeting meetings, where people get together and there's this whole social connection. It's different. Nobody wants to stay in this world for any more than, one day longer than we have to. But do you have concerns about the effectiveness of online AA meetings?
Well, it's second best, right? I mean, it's kind of what we have right now. We're doing everything via telemedicine and this kind of format, this Zoom, format. And as you say, there's something that's lost, obviously. There's a lot to be gained from this. If we didn't have this, what would we do? Thankfully, we've got this technology that enables us to, in real time, in a very fluid way, be able to communicate and see one another and all, which I think is very good. It's probably 80% of what we might get in a room if we were in a room together. Now, here's the thing that's absent, of course, and you alluded to it, is the social connection that occurs before and after, what people call the meeting before the meeting after the meeting. It's that social cohesion that occurs in the more informal ways outside the structure of a meeting. That's what gets lost. And this is why it's so tough right now for people who are trying to get into recovery. People who are trying to get into recovery right now, it's a very difficult time because they don't have that informal social gathering before and after, because typically people go to the online meeting and then they come off the meeting and it's the end. They don't, people don't hang around and chat on the Zoom, format, as it were. So that is definitely one downside. But again, it's the great advantage right now is that we have this technology that people can at least access this kind of telemedicine approach. Exactly.
So along the same lines, outpatient treatment providers have had to go online. I actually talked to one very large one recently, and they said their outpatient census is actually up. And I think that's unusual. They're a huge brand name. But what is your opinion of teletreatment? And in the context of, you're aware that we don't have enough excellent treatment around the country. And there's certain areas that it's very spotty in terms of what's available. So 2 questions. Do you think that teletreatment is a possible solution to the cost, reach, and availability question? And then what are we losing in the translation?
Yeah, good questions. There was a review of the literature, scientific literature, similar to what we did in this study with AA, that was published in the Journal of Substance Abuse Treatment about a year or so ago. And they compared telemedicine approaches to face-to-face approaches and found that they were just as good, interestingly, for substance use disorder. So yes, so anyway, under those circumstances, for those studies included in that review, they found that telemedicine actually can work pretty well, maybe as well as face-to-face, which is very encouraging when, as you say, Steve, the people live in rural areas where they don't have easy access to qualified, quality professionals. So, and now with telemedicine that we have this ability to be able to reach a lot more people and help a lot more people. The question may be engagement. It may just be, some people are hungry for treatment and they're motivated. For other people, we have to engage them a bit more. And sometimes that can be a little bit harder with telemedicine approaches to get that initial engagement.
Yeah, well, the one thing we do know is there's AA meetings in not every, but almost every church basement. And, they're ubiquitous. So maybe the combination of teletreatment and, meetings, once people are able to go face to face, could be an interesting solution to this problem that we have, which is not enough quality treatment available in all the corners of the reaches of the country and the world, really.
Mm-hmm. Yes, exactly. And again, it's recovery by any and all means possible. So, we need to utilize, because this kills so many people and causes so much misery among those people and the family and heartache, that anything we can do to maximize the chances of engagement with something that can help them, the better. If we can synergize and do some professional plus get these freebies, mobilize, activate, help people utilize what's free available, like AA, as well as professional treatment. I think that's probably the best combination of things that we can do to help more people sustain recovery and stop the heartache in families.
Yeah, one thing I will say about AA, and like I said, I've gone to open AA meetings, but the culture is so welcoming and supportive. It's quite amazing to witness. So here's a tough question for you. Have I missed something big that you're saying to yourself, Steve, you got to ask me this question?
I don't think so. I think you've asked a lot of really excellent questions. I think we've covered a lot of bases. And I think we've covered, kind of the questions pertaining to AA and 12-step treatment regarding clinical and public health utility, the cost benefits. I think that's good news for societies around the world where AA is prevalent and present, that we have a free resource that works. When we have treatments that link patients, proactively link patients to this free ubiquitous resource, patients do better. This is very important when you consider substance use disorders, the economic burden, let alone all the rest of it. The economic burden associated with substance use disorders is reckoned to be about 600 to 800 billion in the United States every year. So anything we can do to reduce that economic burden by helping sustain remission, that's good news. And we have something free in these 12-step communities around the country. I think, in terms of extrapolation, you use that word, infer and extrapolate to other kind of groups. I think also, we have 12-step groups, but we also have other kinds of groups too, like Smart Recovery, like Life-Ring, Women for Sobriety, all the Celebrate Recovery. So all these other mutual help groups, which are now growing and emerging all over the country and growing in size and frequency of meetings, I would extrapolate that those entities also would confer a similar level of benefit if they were as ubiquitous, and they are growing. And we have a lot in Massachusetts of Smart Recovery and other groups. As they start to grow, they will provide yet another type of pathway and resource for other people who don't want to go to AA, but still want that peer support and free recovery support in the communities in which they live. And these other entities can also provide that, I think, in equal measure in terms of the magnitude of the benefit, because they contain many of the same therapeutic elements in terms of the installation of hope, universality, catharsis, cohesion, and so on.
That was just an awesome summary. Your study is an incredibly important contribution to the addiction recovery landscape. This has been such a treat for me personally and for our audience to spend this time with you today. Thank you. Thank you for giving all of us your insights on this groundbreaking research. We have all learned quite a bit.
Thank you, Steve. You're very gracious. I'm delighted to see you, and it's great to come on Shatterproof. And thank you for all the work that Shatterproof does. It does an amazing job, and I'm honored to be on this show with you. And thanks for having me. Appreciate it.
Thank you.